Hey everyone, welcome back to another session with Fresh Dental Shadowing. Today we have Dr. Chen. Thank you so much for joining us. And whenever you're ready, you can take it away.
Hello everyone. Thanks for having me, and I hope everyone is having a nice Saturday. Today, I'm gonna give a brief introduction about myself, go over what residency I'm currently in, and then go through some cases that I see on a daily basis. And then I'll probably share some pre-dental advice that I think can be helpful throughout, and then hopefully we can do the Q&A session afterwards. So brief intro about me. I was born in Taipei, Taiwan. I grew up in Taoyuan. There's a picture of me in the upper right of me and my older sister. I moved to Cupertino, California for 5th grade and went to UC Santa Cruz for college. There I studied bioengineering with a molecular focus and a minor in bioinformatics. And going to college, I really had no idea what I wanted to do as a career. And even during college, I couldn't really make up my mind because, I had a lot of interest and a lot of passion. I liked all the classes I was taking. I liked bio. I liked the engineering classes I was doing. But growing up, my sister was a pretty big part of my life, and she decided to be a medical doctor. So I felt like I kind of knew that I wanted to be in the health field, but I didn't kind of want the crazy and tough lifestyle that she had, since I saw it kind of like firsthand. And then one day I had the opportunity to volunteer for a dental organization. And after doing it for a while, I thought that I probably really enjoyed doing this. So I decided to apply for dental school. I ended up going to my number one choice at UCSF. And I think some factors I considered when I was choosing dental schools, including things like, location, where you want to be, if you want to be close to family, or if you like the city. Obviously, costs. Public schools are considerably cheaper than private schools, although still pretty expensive. And the fact that UCSF is a pass no pass system, which I really love and came to appreciate more after going to dental school. I don't think I really realized it before applying. And I think it's something that I can share with you now retrospectively. It is still stressful, but the pass and no pass system, I think it takes some pressure off of you, and it lets you focus on some more extracurricular activities that you're interested in. I think especially because you realize once you're in dental school that there's so much more options that you can pursue. There'll be many fields of specialties that you might be interested in, and you might want to spend time kind of cultivating and preparing for those residencies. So that's definitely something to consider when you're applying to dental school, because some schools are still graded, like UOP. And then UCSF also has a lot of research opportunities as well. So if that's something you're interested in, that's also something to look into. During the summer, from your first year to your second year, you'll have 3 months to do a summer research project if you want to. And there's a huge variety of topics. And then as you go through your next 3 years, you always have the opportunity to do research projects as long as you want to and you have the time and commitment. And then UCSF also has a DDS PhD program. So these are kind of the things that I considered when I was choosing programs. I'm sure there were others as well, but it has been a while. Now I'm a resident, Native American Health Center. I'll go more into that a little bit later. But I'm also planning to apply this year to an endodontic specialty, which is just a root canal specialist. And actually, I just sent in my application recently too. Just kind of continuing the intro, like I mentioned before, I didn't really know what I wanted to do, but I did a lot of exploring, and dentistry seemed like the best option in terms of the lifestyle I wanted, the mixture of science, research, service, and kind of using your hands. So I just kind of decided to go for it. And I think that's my first advice that I have, which is I think you'll never know what a career completely entails until you're actually in it. So I think it's normal to have a lot of doubt, but sometimes you have to go for it or you won't make any progress. And it's okay to change your mind. But obviously, you want to put some thought and research into it. My second advice is, to really enjoy dental school. I think before starting dental school, I talked to a lot of dentists, and a lot of people told me, dental school was really hard and they would never do it again. And just kind of hearing that gave me a lot of stress and a lot of nervous anticipation, where I even questioned, do I want to go to dental school? But once I was in dental school, I realized that school was really hard, but the work was really rewarding. And I think the people you meet is really priceless. So I feel like you really get to make lifelong friends that you spend kind of every day with, and you struggle together. So I would say that you go from really hard study sessions and catching your colleagues fall asleep in class or in the library, to fun research conferences in Florida, to struggling in sim lab because you have to work with your hands for the first time, to working on each other and giving each other anesthesia, which is a pretty fun experience, kind of scary too. And then to getting inducted in clinic and actually seeing patients for the first time and going on rotations together. All the while, you're gonna have enough time to have a lot of fun trips, volunteer events, game nights, gym sessions, and so on. And I think what you realize is that these friends, they'll help you navigate through many first experiences together, like being an associate, buying your own clinic, referring and asking for help from your own friends who now became specialists. So I think school is hard, but you want to enjoy the process and you want to try to really learn for the sake of learning and kind of being the best dentist you can be. So looking back on my application, I just want to give a quick disclaimer as well. It has been more than 4 years, so I might not remember the details of the application process. And I'm sure things change with time too. But if you have any questions about big picture things, I would be happy to answer them. So you can see my DAT scores and my GPA. I think it's pretty average, except for maybe the math part of the DAT. And I think my third advice is the biggest advice is that while I think grades and test scores are really important, I think you want to focus on just a few activities that you're really passionate about. And I think it doesn't always have to directly relate to dentistry. And I think it's better than instead of doing a little bit of everything, it's better to delve really deep into 2 or 3 activities that you can really involve yourself in. And I think this is kind of especially helpful for interviews because they'll ask you about your experiences, and I think it's better to be able to talk kind of very passionately and in detail about something you're involved with, rather than a lot of little small events that you can't really talk too much about. For me, it was research and dentistry. But some of these things cross into each other as well, like dentistry and volunteer. These 2 subjects, they come hand in hand. So for me, for 4 years, I worked as a volunteer researcher at the bowel lab in my college campus. I was working with C. elegans to study mitosis, meiosis checkpoints, and that led to a poster presentation at the Bay Area at one meeting, and then a very small publication for simply being involved in the graduate students project. I found out about this opportunity just going on our school website, looking through a bunch of PI's research goals and emailing them the ones that I thought had really interesting work to me. And, just remember that the PIs are usually pretty busy, so don't be hurt or don't take it personally if they don't reply or if they don't need you for now. I think eventually you'll find a good fit. So you just want to be courteous and be eager to learn and work hard. During my summer, my other main activity was assisting at a bi-monthly free dental clinic that did exams, cleanings, extractions, and fillings for low-income patients. And that was kind of my introduction and connection with dentistry. And that was pretty much it. I didn't do a lot of fancy volunteers. I wasn't a part of many organizations. In fact, the Pre-Dental Society was pretty much all I was a part of. And while it was a great organization, I wasn't actually involved in a whole lot of board activity as well. But the president at the time now graduated from University of Michigan, and some other members also went to UCSF, EOP, and other schools too. So I think the Pre-Dental Society is really nice. It's a really great place to share information and help each other out. I think this organization too, it's a nice place to share information with each other. But I think what I realized is when you really put a lot of time into 1 or 2 things and you're passionate about it, people will naturally recognize it. So I think that's a good way to meet mentors who can write you a strong recommendation letter rather than a professor that maybe you rarely ever talk to. For me, my research PI was really helpful because I worked with her for 4 years, and I think she could really attest to my work ethic and my qualities. And I think even if you have a big class, which a lot of universities do, I think if you're passionate about a topic I would go often to office hours, ask questions, and you interact with the professors more, especially in a large classroom setting. Although maybe right now that's not super relevant if classes are online, um, but hopefully it'll return to normal. So right now I'm in a program called AEGD. It just stands for Advanced Education in General Dentistry. It's an extra 1 to 2 year training after dental school. In dental school, you don't get as many experiences that might prepare you for quote unquote real world dentistry. You get to learn more difficult skills that you can't learn in dental school, like surgical extraction, difficult root canals, like molar root canals, implants, and so on. Some schools you might have more experience, some schools you might not have as much. For me, I wanted to improve my overall ability as a general dentist, work on my speed, but also do more root canals because I wanted to see if I really wanted to apply to endo specialty. And I think an extra year of general dentistry training is kind of a great place to figure out if you're interested in specializing if you were previously unsure. You get to see what procedures you really like or dislike doing. Another benefit of residency compared going straight to work is that you can try more difficult cases under the supervision of a licensed dentist. And when you go straight into private practice, you might not feel comfortable doing procedures that are outside of your comfort level because no one's going to be able to help you if you can't complete it. So likely you won't be doing as many challenging cases, and we'll probably do a little bit more referrals unless you feel very comfortable. So personally, I think it's good for most people to do a residency. It's only an extra year and 2 if you want to. And I think it's a place where you'll be paid to learn new techniques, although a very low pay, rather than later down the road where you pay a lot more money to take CE courses to kind of enhance and improve your techniques. Another benefit is that most people, when you go to dental school, after you're done, you're going to take the REBS, which is a live patient exam to get your licensure or your license. And it's accepted by many states. But because of COVID, the last 2 years, it was actually on mannequin and typodont. But alternatively, if you do AEGD or GPR, which is like the other type of residency, you can have the option to get licensed through your residency instead of taking the exam. But only about 7 states take these, and those are listed. And Washington specifically requires you to do your residency in their state. But 46 states will still accept you without any extra examination if you practice for 5 years continuously. So if you already know where you'll be, like California or one of these states, I think it takes off a lot of extra stress and kind of financial costs from taking the REBS exam. And especially if you fail the REBS exam, you can get licensed through residency until you pass that exam. I mean, which you don't really need to anymore, but the REBS exam used to be more stressful because the live patients, they're not always the most reliable, like whether they'll show up or not. And then the selection criteria for your cases can be more strict. But if the typodonts are adopted permanently for the future, I think it's not a bad option either. We just don't really know what's going to happen. But, because REBS can give you more flexibility for different states if you're not sure where you want to be and you know that you might go to different states. So after finishing dental school, you have many options like private practice or corporate or FQHCs, which is just community clinics. There are many pros and cons for all, but I kind of want to talk about community clinics because I feel like it's a lesser talked about topic, and it's what I experienced this year in AHD. But I think the bottom line is you really want to choose what makes you happy, and I think what I recommend is to try everything actually, and you can decide later as well. I think you can do 2 days at a community clinic, 3 days at a private practice, just to see, which style you enjoy more. And I think the most important thing to look for when you're looking for a job is whether their practice philosophy aligns with your philosophy. So I'm finishing my residency this month, actually, and I've been discussing some job opportunities in the Bay Area, and I'll be doing exactly that. I'm going to work part-time in private practice and then hopefully part-time in community clinic as well. So my AGD clinic right now is an FQHC, which stands for Federally Qualified Health Center, basically a community clinic for the underserved population. At our clinic, we do mainly bread and butter dentistry, but there are other community clinics that do more as well. They do more aesthetic, more advanced treatment. It just depends on the clinic. What I like about FQHC, I think, is the patient population. They are the patients who really need a lot of work, and that will really substantially change their lives. You'll see rampant large cavities that you might not see in wealthier or more affluent populations as a private dentist. And personally, I think it's very rewarding because of how grateful the patients are. Compared to private practice, I also feel like you feel less pressure to produce because the clinic is paid based on the patient visit instead of procedure. So I feel really good that I can kind of take my time to focus on the quality of my work without really feeling rushed. But I think as we get more experience, it probably won't be such a big problem as well. I think private practice has many of its own advantages too. Now, I think the only main disadvantage I can see being an FQHC is kind of a lower pay or the inability to be your own boss if you're an employee, and possibly living in a less exciting living location. But another advantage of working at a FQHC is the loan forgiveness aspect. I'm by no means an expert in this topic, but there are some things you can look into yourself. There's a program called the National Health Service Corps, which has two programs, a scholarship program and a loan repayment program. The scholarship program will pay for your tuition, your educational expenses, give you a monthly stipend in exchange for 2 years minimum service. But if you receive more than 2 years, you would just work the equivalent years for as many years that you borrowed from at an approved health professional shortage area. So that's something that you can apply for if you were accepted to dental school or if you're in dental school. And it is a little bit competitive though, but I think it's a pretty great program. On the other hand, if the loan repayment program offers to repay your loans up to $50,000 in exchange for 2 years full time. But with continued service, you may be able to pay off all your loans. There are also other ways that might be a little bit less competitive. If you simply work for an FQHC for 10 years while making 120 payments, your remaining deferral debt will be forgiven. Again, this isn't part of the NHSC. I think it's just government incentive for people to want to work in FQHC settings. So going to what my day looks like as a general dentist and as an AEG resident, I currently have 9 to 5 work days, 5 days a week. And then general dentistry includes, restorative, which is, fillings, crowns, perio, which is cleaning, deep cleaning, some surgery, endo, which is root canals, pros, things like dentures, oral surgery, extraction, implants, peds, working with kids, and then orthodontics is braces. And then there is a lot of other subspecialties as well. What I love about dentistry is, there's so many variety and opportunities depending on what you're interested in. You can work in a private practice, a community clinic, and as you advance through your career, you might also choose to teach in a school, or even when you retire, you can do research, and there's so many things you can do. But I'll go through the cases now, some of the cases that I see. For some of these cases, I don't have all the information, especially the ones that I did in dental school. Once I started residency, I started documenting my cases more rigorously. And I think that's another tip that I would give is once you guys enter dental school. I think dental school is really hectic, especially in clinic and when you're new to everything. But if you put in just a little extra time after hours, to keep a record, keep pictures of your interesting cases, even if they're not amazing cases, I think it'd be really fun, and it helps to track how you improve and grow. So this is my restorative case, which is treatments like fillings, like crowns. And I did this one in dental school, so I don't have all the details on the medical history, but the patient was a 24-year-old male who was relatively healthy. He had a rampant decay, most likely had meth mouth, even though he denied the usage. But here I placed amalgam filling, which is basically the metal alloy or silver fillings you see. Both of these teeth that you see are on the same patient, and the cavity was really deep and close to the nerve. So if you look at the picture, this black part that is being pointed by the red arrow, you can see that's the nerve. And then you can see the cavity which is outlined by the white dotted lines. The cavity is really, really close to the nerve. So what I did here is I placed what's called an indirect full cap. And basically, you remove all the cavity, you leave a little bit of cavity right near the nerve instead of removing everything and accidentally hitting the nerve. And you put a little medication right near the nerve to kind of soothe the nerve, promote healing, and then you put a little base and fill the cavity. And this way, you can avoid having to do a root canal, but it only works if the patient's nerve has a healthy status, healthy response. And this is a little bit controversial because the literature supports it, but generally it isn't super widely adopted by a lot of dentists. And then my next case is a number 29 crown, which is still restorative. And the patient is 45-year-old female with high blood pressure. She's taking atenolol for her blood pressure and along with some aspirin and ibuprofen. No drug allergies, no social history or surgical history. And this was the case where I did the root canal and then the subsequent crown. The crown, pointed out by the red arrow, is the restorative part. When we're doing crowns, there are many things we strive for, like aesthetics, making sure the color matches adjacent teeth, and asking the lab to maybe even put different shades in different parts of the teeth. In my case, for this case, I didn't have a perfect color match, but the patient liked it. And since it's in the back, in the lower jaw area, it's not really an area that can be seen when you're just talking or laughing. When you're cementing a crown, we also look out for a lot of things, like the bite, the aesthetic, and very importantly, the margin. So here you can see in the X-ray from a different case, because the contact is really tight, the crown isn't completely seated. So you can see in the red arrow, you kind of see like a little gap or a little black shadow. That's kind of like the crown hasn't seated completely yet. So what you have to do is you have to keep kind of adjusting the crown, the contact, so that the contact isn't so tight, and then the crown will fully seat down. And then now you'll see at the last picture, it's completely sealed. There's no gap there anymore. Failure to completely seal the crown or seat the crown can result in an occlusion that's too high. So like when patients bite down, it'll feel really high, or you'll have an open margin where that kind of allows the bacteria to infect and get in between the tooth a lot more easily. So this is part of dentistry that I enjoy, because I feel like dentistry is very detailed and it involves a lot of problem solving until you get what you want and what the patient wants. And then the next case is we also do pros as a general dentist, and that includes dentures, partial dentures, fixed prosthesis like implants, implant retained dentures, bridges. But at our clinic, we only do the bread and butter pros work, which is complete dentures or partial dentures. Partial dentures have two main types. You have a resin base, which is this one called a stay plate, or we have a metal framework, metal partial dentures, which we just call RPDs. The resin-based partials are more for aesthetics, and they're kind of a cheaper option, but they're not very strong for eating because they don't have like a metal plate underneath. But the metal partial dentures can be more ugly and with the metal, but they're more expensive, but they're more strong for eating. So we give the patient the ideal recommendation, and the patients can choose what they want based on their financial and personal needs. And then for dentures, this was a case that I did in dental school. So I don't have the relevant medical history, but it's a pretty straightforward case. Basically, it's just a denture to replace the patient's missing teeth. Although it's not super fancy, sometimes dentures can be very rewarding because the patients feel so much more confident and they're thankful when they have teeth, even if they're not the most stable option compared to implant retained dentures, or obviously their own natural teeth, but it's much better than when they had no teeth. And then the next part, we do daily. What we do daily is also oral surgery, which includes extractions, implants, and so on. As a hospital oral surgeon, if you specialize, there's a lot more big surgeries that you do, like orthodontic surgery, trauma, biopsies. For general dentistry, mostly it's just simple and surgical extractions, or even implants too. At our clinic, we don't do any implants. But this is also why I wanted to do residency, because at dental school, you're very limited with simple extractions. Maybe other schools are a little different, but at UCSF, mostly they let us do kind of more simple extractions, unless you go on your rotations. Then you get to do a little bit more complex ones, but day to day, you don't do too complex extractions. But for extractions, we want to evaluate, is patient's blood pressure safe for extraction? Is patient taking any blood thinners or bisphosphonates, or if they have radiation exposure that can lead to osteonecrosis? If you know that patient's going to have these kind of treatments, like the radiation treatment in the future, then you want to be a little bit more aggressive with your treatment now, because after their radiation, you won't really be able to do the extractions because they can lead to more complications. So here you can see in the upper left, this is what would be a simple extraction. There's not much bone surrounding the teeth, and this kind of extraction usually comes out more easy. And if you look at the picture in the right, there's more bone here, and you can see this molar tooth has 2 roots, and I had to section it in half. And I do this because you can see that the 2 roots make it more difficult to take out because there's a lot of bone in between that locks the tooth in. So when you section the tooth and cut it in half, it makes it a little bit easier to take out because they become basically 2 individual single-rooted teeth. And this is kind of like part of the surgical extractions that you would do. And in this bottom picture, I did in dental school at UCSF. You actually get to treatment implant crowns. You shadow the surgery. You don't place the implants. The oral surgery residents or the oral surgery doctors will do it, but you get to restore the crown, and it's a good experience to learn how to treatment plan a crown that's on an implant. And then perio, there's a lot of different surgeries that you can do. Like implants, they do implants as well. They do tissue grafts, they do osseous surgery, and a lot more. But for general dentistry, at my residency, I mainly do prophies, which are just regular cleanings, SRP, which are deep cleanings, and then some soft tissue surgery, like with a laser, and then some surgical crown lengthening. To kind of explain what surgical crown lengthening is when you want to place a crown, you have to have enough space between the margin of the crown and the bone. We call this biologic width. It might be a little bit too detailed, but in short, you just have to know that, if you have a fracture or a cavity and it's really close to the bone, you have to create a space so that you can put that crown on. And you do this by surgically lowering the bone to expose more of the tooth to place the crown on. And so this is the case that I did in dental school. We had a perio clerkship where you get to work with a periodontist to learn some more advanced perio surgeries. And this is a small program that you apply for if you're interested. So I was really grateful actually for this opportunity because it helped me a lot in residency as well. I felt more independent and I was able to do some of these cases myself. And I think that's also why I really like my education at UCSF. So you can see in the top row, there was a certain part of the tooth that's exposed that you can see with that. I drew a little thin red line, but it's too short for a good crown. So after crown lengthening, you'll see more of that tooth exposed. So you see with the red line that the tooth part is the tooth that has been exposed after lowering the bone level. And the blue part is just a filling on the tooth, or what we call a buildup for the crown, basically. And then my personal favorite, endo. So I am applying to endo specialty this year, so we'll see how it goes. This patient is a 48-year-old female without any medical history complications, not taking any medications. But basically, patient had a crack on her number 30 tooth that led to her nerve becoming necrosed, or basically her nerve dying. And what that means is the crack probably extended to the nerve, and then it allowed bacteria to travel from outside of the tooth in your mouth into the nerve and infecting it, causing the nerve to eventually die. So you can see the crack in the upper left picture with the white arrow pointing to it. And then if you look at this kind of black circle that my red arrow is pointing to, basically that's the infection that has traveled from the top of the tooth into the bone. So that's an infection in the bone. And I think what's really cool is if you look at the red arrow, you can see that the bone has filled in and has healed 6 months after the root canal was done. So you can actually even see some of the bone filling in the 3-month picture. But in the 6-month picture, it's a lot more obvious that bone is filling into that infection defect that was there. So what you do in a root canal treatment is basically you clean out the inside of the tooth and then you fill it in with material. This was a pretty hard case because if you look at it, the canals were pretty narrow. So actually one of my instruments broke and separated in the tooth. So we actually have to retrieve that as well when that happens. And then the distal root, just basically one of the root had 2 canals in it that joined together. So that's very challenging and difficult to navigate through. But the results were pretty successful, as you see in the 3 months and 6-month recalls. And the great thing about endo is when patients need endo, oftentimes they're in pain. So when they come to you and you complete the endo, hopefully if your endo is successful, they will be out of pain. And that's part of it that I really like as well. And then the last one is pretty cool. 24-year-old female who came in with a swelling in her lower lip. The swelling is soft, kind of fluctuant, slightly blue. Patient was pregnant but had no other medical history, wasn't taking any medication. And this is what we call a mucocele, which is a benign condition, and it has 2 types. So the one type is called a mucus extravasation, which is when you have a trauma to your salivary glands, like if you bite on your lips a lot, and then the salivary gland gets severed, and the mucus spills into the surrounding tissue, and then causing it to swell up. And then the second type is called a mucus retention cyst, and that's basically, it's similar. It's just you have a blockage in your salivary gland, and it causes it to swell up. But both cases, you would just remove them, and you would send them for a biopsy to confirm your diagnosis. Here, I used a diode laser at 2 watts continuous setting to remove the mucocele. And what's important here is you want to completely remove the salivary gland and any adjacent ones as well. And this is important because the mucoceles have a really high reoccurrence rate. So if you don't remove it all, they can come back pretty easily. And then you can see in the bottom right, the lesion healed really well. And there's actually many ways to remove this mucocele, like the conventional way where you cut it with a scalpel and then you suture the wound. But I think the beauty of the laser, and also the fun part of the laser, is that it cauterizes the nerves and it kind of seals the wound. So it doesn't hurt a lot, and there isn't a lot of bleeding, as you can see in the lower left picture, which is just immediately after the surgery. And yeah, so I really love using the laser. It actually has many other uses too. So it's very, very versatile. But yeah, that's all I have for you guys today. And if you guys have any questions.
Thank you so much for the amazing presentation. We do have some questions from
Sure.
the YouTube and Instagram, and I'll kind of just go in a random order. Okay, so did you take a gap year before dental school? And even if you did or didn't, what do you suggest pre-dental students do if they do have to take one?
Okay. I didn't take it. I didn't take a gap year. I went straight afterwards. I applied in my junior year, I think. So I went straight after. I think kind of like what I said before, if you have a gap year, I think it's just kind of spending that time doing something that really interests you. And I think it can be, if you like doing research, you could do research, or if you like, or if you want more dental experience, just kind of assisting as a dental assistant, or shadowing, or volunteering. But I think picking one thing and just kind of sticking to it, or even just like, I think even working, if it's something that interests you, it's always something that I feel like there's almost always a way to tie it back to kind of how you care about dentistry and some aspect of dentistry. So I think just picking something you like doing and doing that for that year. Yeah. Or, if you're preparing for the DAT, that's also a really good time to be studying for it as well. Yeah.
Gotcha. Thank you. So you mentioned your sister is in medicine and you didn't want the same lifestyle. So what are some of those changes that you see in dentistry? I guess like comparing the two and like
Yeah.
what you found helpful?
I think kind of the surface level, because I'm not, I didn't go to medical school, so I wouldn't know for sure. But just
Yeah.
hearing my sister talk a lot, she often has to go on night shifts, 24 hours, and she gets called in at weird times. She only right now, because she's a resident as well, and she's almost done with her program too. But she works 6 days a week, and yeah, and it sounds pretty hard.
Oh, wow.
So
Yeah.
I think as a dentist, you have a lot of flexibility. In dental school, it's a little bit hard. Like you have to study a lot as well. But after you start working, you start your day. If you're an associate, you don't own your own business. You go to your 9 to 5. When you're done, you go home. You're kind of done with your work,
Right.
and you have that flexibility where if you are comfortable enough, you're happy enough with what you're making or the amount of work you're doing, you don't even have to work 5 days a week. You can work 2 days, 3 days, or especially if you become like a practice owner, you might have more flexibility too. If you're hiring people to work for you, I think those things are kind of.
Yeah, gotcha. Would you ever consider having a private practice or?
Yeah, I think I certainly would. I think that's kind of the dream, I guess, for most students in the beginning. And I think I'm certainly interested in it as well, but I can definitely start to see kind of the stress of owning your own practice, because there are a lot of things that go into it. You're managing your own clinic. You have to hire employees. It's not easy. But definitely, I think there's pros and cons. I think these days I'm leaning a little bit more towards. I think I might be okay with being someone's employee.
Yeah.
But I can see the appeal too. I think it depends on the person.
Gotcha. And do most specialists own their practice, or is that kind of more just general dentistry?
I think I think it's pretty similar. Like it depends on the person. I know a lot of specialists will kind of work with a general dentist. Like if a general dentist has a clinic, it's almost kind of like contracting work where you go and then you work at that clinic, and it's easy because then you don't have to buy a lot of equipment yourself. You can just go and work. But there's also a lot of specialists who open up their own clinics too. It just depends on the person, I think, and probably on the specialty too.
Gotcha. Thank you. So you said that you had the pass or fail system. So is there class rank, or how would that be determined, and how does that affect like different specialty programs if they look at your grades, or how do they assess I guess how you did in dental school?
Yeah. So I mean, the school always tells us like technically there's no class rank. I'm not exactly sure, but I think there is some kind of class rank. I think if you are in the top percentage, when you apply for residencies, you have to ask for a dean's letter from the school. And I think if you are in a top performing percentage, I think they'll include that in your application. But they don't tell you. They're not going to tell you saying like, oh, you are ranking this in a certain level. There is like if you do well in your tests and your classes, your exams, we do get honors. And that's something that helps you stand out as well when you're applying to a specialty. But I think most schools kind of know, like when they know that, oh, you're applying from UCSF, they know you're a pass, no pass. And usually you'll have other things on your application that you talk about, like the club activities that you're a part of, the research that you do, or the volunteering events that you do, things like that.
Yeah, gotcha. Thank you. So what you said that you want to go into endodontics, right? And what are some reasons that are kind of pushing you to specialize? And have you considered other specialties, or like why this specialty?
I think once you guys become general dentists, you will realize like general dentistry covers a lot of things. So I think you have to become really good at many things. And I think most of us are equipped to do it. But you also sometimes you'll realize like, oh, I'm particularly good at something else, and I enjoy doing this more. And I think it's just kind of your personality. I think I'm really drawn towards endodontics, just because I feel like it's very detail oriented, and you kind of, when you're doing your root canal, you're just kind of focused on that one tooth, and you're kind of trying to finish the root canal kind of, I guess, to perfection, and I think that really draws me to it. Yeah.
Gotcha. Okay, so how do you think dental school was different than residency? So like now you're nearing your end of residency. So how kind of do you compare yourself in the beginning and now to the end versus getting straight out of dental school?
Yeah, when you're in dental school, there's a lot of procedures that you have to go through. So there's a lot of paperwork. You know, you need to get pre-authorizations before you can start a procedure. So basically, it kind of just it slows you down a little bit. And it's in a way, it's not terrible. Like I think there is meaning to it. You know, when you're first starting, you don't want to be cramming yourself with a ton of things and being unable to handle it. So in dental school, when we're in school, usually you have a morning and afternoon appointment. You'll probably see one patient in the morning, one in the afternoon. And as you get a little better, you might see two in the morning, two in the afternoon. But that's usually the extent of it.
Yeah.
And it's kind of slow because most of the times you don't have an assistant. You're working by yourself and you're a little bit nervous too. It's your first time doing things. It takes a little bit more time. But at residency, you know, before COVID happened, they used to see 2 columns a day, which is like probably like 16 patients or maybe less. But right now, because of COVID, they want everyone to just have 1 column. So I see like 8 to 10 patients a day, maybe. But it's a lot faster, right, compared to dental school. And it's a lot nicer because you have assistants for every procedure. So you can kind of just focus on doing your dental work. You don't have to do a lot of paperwork in between just to get approved and checked and things like that.
Yeah.
So I think it helps a lot. It boosts your confidence, I think, before going into like private practice work.
Right. Yeah. So in residency, is there like a senior doctor kind of guiding you, or is it like how is it set up?
Yeah, so most of the times you will have a supervisor or attending basically. And, you know, if you have any questions, you run into trouble, then you ask them to help you. But the nice part is like when you're in dental school, basically every time you did something, you will ask a faculty to come check, right? Like you start a prep, the faculty would check it, they'd be like, okay, that looks good. And then you fill it. But I think in residency, most of the times, you know, you're on your own. You're basically your own doctor. You do what you want to do, and then when you run into trouble, you help. Then you ask the faculty to come take a look. But sometimes when you're first starting, you know, because they wanna be able to trust your work, they might check your work the first few times, and then they're like, okay, this doctor is pretty competent,
Yeah.
knows what he's doing. Then they give you kind of the reins, and then you just ask for help when you need it, basically.
Gotcha. So you mentioned briefly, like you do get paid for residency. So, do you think in the long, or I guess, what like are the financial pros and cons? So, do you have to pay tuition, or, yeah, I guess just more about
Most
that.
of the 1 year residencies right afterwards, you don't have to pay a tuition; they'll pay you. It's just pretty low pay
Yeah.
compared to if you go to private practice. I think it's like around. Well, it probably depends on each school, but for us, it's like 40K a year, around that area. But if you're doing a different specialty, like if you're not doing just that general dentistry for an extra year, some programs pay you, some programs you have to pay tuition. It just depends on what program you're applying to, which school you're applying to. And those are things you can easily find out when you go on their school website for schools that you're interested in. Yeah.
Thank you. So you mentioned that you're doing an AEGD, right? So what is the difference between GPR and the residency that you're a part of?
Yeah, so they're both like a 1 year general dentistry program, and you can get licensed through both of them. The GPR one is just hospital based, so you're kind of working in more of a hospital setting. The point of it is to be able to learn more about medically complex patients and being able to manage and handle those as well. So you might even go to the OR and do some work in the OR as well. But for AEGD, it's more strictly just dentistry, general dentistry, and even more advanced dentistry. You know, you're not going to the hospital to do the OR and things like that. And that's kind of like the main difference. Otherwise, they're pretty similar.
Gotcha. So you mentioned medical history and more complex cases. So do you have an example of maybe like how the known medical history or maybe known medications have helped you with diagnosis?
With diagnosis?
Or like just how you went about
Well, I think like kind of like the example I gave before, you know, like knowing the medications like bisphosphonates and things like that. It's like you kind of have to be aware and keep it in your mind, like, oh, this patient is taking this kind of medication. Is it safe for me to do these treatments, like the extractions? Or if the patient is planning to take these medication in the future, how should I adapt my treatment now? You know, like maybe I should be like, maybe this patient, like the example I showed earlier, where the patient had a really deep cavity, right? In those cases, when you do a deep cavity like that, it can either be okay or it can worsen, and then patient starts to have pain.
Yeah.
And let's say the patient needs to extract the tooth. It would be hard if you didn't consider the medication and you kept that tooth like that. And then now they started taking the medication, they need to get the tooth extracted. But then, you know, if I extract this tooth, you might have some complications like osteonecrosis where your bone starts to die. So I think kind of knowing that, if you knew that, you wouldn't do the indirect pull cap. Instead, you might say, okay, we should probably extract this tooth, especially if you don't like, if you know that the patient doesn't have good oral hygiene, things like that. So I think those kind of stuff, you know, there's more to it. But also, like, if you go to the OR, you can actually, like, if you go to GPR, you can actually sedate your patients. So like patients with severe anxiety, or if they have some disabilities and they need to be sedated, those are things that you do in GPR as well that you won't do in HGP.
Gotcha. Thank you so much. So in the second case, you mentioned that the patient didn't have the root canal complete in one visit. So why is it sometimes broken down into multiple visits? And what are each visits kind of geared towards?
In the root canal case?
Yeah.
So sometimes you can. So root canals can often be done in a single visit, or sometimes multiple visit. Usually, I mean, I think sometimes when the root canal is pretty difficult and you're starting, like a molar root canal, if you don't have a lot of experience, it can be a little bit more challenging. So the first few cases that I do, it took me more than one appointment, sometimes even more than two appointments just to finish. So that's kind of a reason, like limitations of your own skills, like your speed. And then the other part is usually when you need a root canal, you have an infection in your bone. So sometimes you'll start the first appointment, and then before you finish it, you want to see some kind of improvement, because after you finish it, it'll be difficult to go back in again. Like let's say you start the root canal and you finish it, and then the patient says, oh, I'm still in a lot of pain after a few weeks or a month. Then you have to go back and take everything out and redo that root canal. And you're not sure, like, did I do something wrong? Or like, if was my root canal successful or not? You won't be sure. But if you start your root canal and you give it, like, let's say a week or two before your next appointment, and then the patient is showing signs of feeling better, or you see symptoms resolving, then you feel more confident that, okay, my root canal was pretty successful and it'll be okay to fill it. So those are some reasons.
Yeah, thank you. So you also said that you had to retrieve your tool from the canal during one of your cases. So how did you do that, and kind of what was it like damaging, or what were some other steps you had to take?
Yeah, so I don't know if you guys saw, but in that picture on the lower left, when we do root canals, we have these really long files that go into the root. And basically when I was putting it in, it separated right at the orifice of the tooth, basically the floor of the tooth. And luckily it separated on the top of the tooth. So if it separates at the tip of the tooth, it gets even harder to take out. But because it separated right at the top of the tooth, I could still see my file. I just couldn't grab it. So what we did was we used an ultrasonic, kind of like the ultrasonic you get when you get your teeth cleaned. Basically, you kind of just vibrate that area until the file kind of slips out, and then you can flush it out.
Cool. Okay, well, I'm gonna move to the YouTube live. So someone asks, are you able to speak about dental school outlooks on students who graduate 4-year state schools and complete prerequisites at a community college. So I guess what they're trying to ask is how does community college look to dental schools if you've taken prereqs there?
Oh, I mean, I can't say for sure because I'm not on the admission committee.
Yeah.
But I think just imagining, I think as long as you take in the prerequisites, I don't think it hurts your application. You know, I have a lot of classmates who also went to colleges like that, and I don't think it really affects it. I think having a strong application is, you know, if you took those prerequisites and you do pretty well, and then just having things that you can talk about that really stands out to you, that you can talk deeply about. I think that's the most important. I wouldn't worry about like coming from different schools or smaller schools or things like that.
Mm-hmm. Makes sense. So would you say that your study habits changed when you went into dental school? And what did that process look like for you?
I think when I was in high school, I wasn't the most studious. I think I really learned how to study when I was in college, just because I think I was a bit more serious, and I started thinking like, hey, I want to go to dental school. Maybe I should work a little harder for my grades to be okay.
Mm-hmm.
And then in dental school, it depends on each school, but at UCSF, usually the first year is kind of the hardest year in terms of academic studying. I think, the habits are pretty same. I think when you're in that environment and you have to study a lot, you're going to do it, but then you also realize, I think the beauty of pass and no pass is after the first quarter, you'll be like, oh, I studied really hard, and I did really well. My score was really high. But then as the quarters go on, you start to realize like, okay, like I kind of know how much I need to study to pass, and you're not as concerned with like, because you still get a score, like you're gonna get 90%, whatever. It's just that on the report card, it's gonna say pass, no pass. So you start to realize like, okay, like I don't have to kill myself to get a 90%, like as long as I understand the important things to make me a good dentist, that's what's most important. And then your habits will probably change a little bit. You might not be as studying crazy hard as you were in that first quarter.
Yeah, makes sense. So you mentioned that there's loan repayment programs and different things like that. Do dental schools offer scholarships, and is there kind of maybe a program that might not ask for service after, and how competitive would that be?
So I don't think there's programs that was like not ask for service. I think if there's a program like the ones I mentioned, they will require the number of years that you receive their support from. For dental school, I think it just depends on the school, so I can't really speak for other ones. I think at UCSF, I think they do choose one student out of your class who's very exceptional, from their college experience, who gets a full ride. But I can't confirm it. I think that's what I hear from my classmates. But you do get like they will give you like some supplements. I think for most students, actually, it's not a whole lot. It's maybe like a couple of thousand, and I think they'll consider your situation as well. So they did give you like little scholarships, basically, but things like that. Yeah.
Gotcha. Okay, so we have time for like 2 more questions. So,
Sure.
for endodontics, I think the root canal is like the major, procedure that comes to mind. So what are some other procedures that they may do, and what is that like?
So for endodontics, it's pretty specifically about root canals because you're just trying to save the tooth. But what makes it a specialty, or like what makes it hard, is like simple root canals that general dentists do, or is like the front teeth, right? They have like a single root, so it's a lot easier. But when you get to the teeth in the back, they get pretty complex. So you'll have roots that are really curvy, or just the fact that it's in the back makes it really difficult to access. And you might have like canals that are really, really small, and you have to work through it, and it's pretty difficult. Some of the other things that we do often is kind of like doing retreatment. So sometimes root canals fail, and you have to redo that. And that we kind of talked about earlier, but those are pretty difficult to do as well. So retreatments endodontists will do, kind of helping other general dentists whose root canal might have some problems, which is normal. Like what happened to me, like if your files get separated and then you can't retrieve it yourself, then you might refer it to a specialist, an endodontist, and he might either be able to retrieve it or he'll work past it. And then there's also they do some minor some surgeries as well. Like when you need a retreatment, sometimes it's not always ideal to redo that root canal. Sometimes you do a little surgery, open the bone up and manually clean out the infection from that bone instead of through the tooth. So things like that.
Gotcha. So is there like a certain point when you can't save the tooth anymore? Or is there a certain amount of root canals that you can do before like you have to extract it or something?
Yeah, so usually that's something that the general dentist will decide. So if the tooth has lost so much tooth structure, then there's no point in doing the root canal because you can't even support a crown, or even if you do it, this tooth could break. So it's not a good idea to try to save the tooth. So to the general dentist will usually decide. So, if it's not restorable, they won't even send it to the endodontist. So that root canal won't be started anyways. But there are cases that are, you start a root canal and it fails or it breaks. These things happen. Then you would extract that afterwards as well.
Okay, awesome. And last question. So when you do a complicated extraction, you said that sometimes there's broken pieces or you have to break the pieces. So how do you kind of make sure that all the pieces are gone? Do you have to take another x-ray or do you look at the previous x-ray and match up the pieces?
Yeah, so usually the broken pieces isn't like, you don't really separate into a billion little pieces. So you're not really concerned like if I left that there. Usually you're just cutting the tooth into like in half or like in the cross where it becomes these individual roots basically. And the individual roots are basically like a single tooth itself. And then you just take each piece out. So usually you already have an idea, when you go to dental school, you know what each tooth is kind of like, how many roots the tooth have. And when you take the x-ray, you also have an idea like, okay, this tooth has this many roots. So when you're taking it out, you're kind of keeping track, like, oh, okay, I took out all 3 pieces, I'm okay. There are also definitely cases where when you're trying to extract the tooth and the tooth breaks and there's a little tip stuck in there. So you might not be sure, oh, did I completely take it out? Then, like you said, you'll take another x-ray just to make sure you got everything out. There's certain cases too, if like the piece is really, really small, sometimes it's actually okay to just leave that in there and it won't cause any problems as well.
Thank you so much. Well, thank you for coming and spending some time with us. If you'd like, you can put up your Instagram and everyone can go follow and maybe DM for more questions. But thank you so much, and we'll see you guys next time. Bye.
Thank you.